Hi everybody, and welcome to our module on Hodgkin lymphoma. Lymphomas are malignancies of lymphocytes like B cells and T cells, and in these diseases the lymphocytes form a mass. That's why it's called an oma. Now the place where the masses often occur is in the lymph nodes. There's lots of B cells and T cells in lymph nodes, so when they become malignant, naturally you often develop large lymph nodes. However, there are also B cells and T cells found in other places like the skin and the GI tract, so you can develop a lymphoma that is what's known as extranodal, meaning outside of the lymph nodes. There are many ways that a lymphoma can present, but a common presentation is as an enlarged painless lymph node, and the word painless is important here because lymph nodes can become enlarged in reaction to an infection, but those so-called reactive lymph nodes are typically tender to the touch. An enlarged painless lymph node suggests a malignancy such as a malignancy from lymphoma. In addition, many lymphomas have what's known as B symptoms. These are systemic symptoms caused by cytokine release, and they include symptoms like fevers, chills, and night sweats. So remember what I told you before, lymphomas have the word oma in their name, and that means that the malignant cells form a mass. So the way you make a diagnosis of a lymphoma is by performing a tissue biopsy of the mass. Often it's a tissue biopsy of a lymph node. That biopsy sample will be examined by a pathologist, and if it's a lymphoma, there will be malignant lymphocytes seen under the microscope. The pathologist will then look for presence of a particular type of malignant lymphocyte called a Reed-Sternberg cell. If Reed-Sternberg cells are present, then it is a case of Hodgkin lymphoma. If there are no Reed-Sternberg cells, but there are still malignant lymphocytes, then it is a case of non-Hodgkin lymphoma. So let's talk about Reed-Sternberg cells. These are the malignant cells that cause Hodgkin lymphoma. They're large cells with a very unique appearing multi-lobe nucleus. I'll show you a picture of one on the next slide. It has two halves that are often mirror images of one another. It's sometimes described as owl-eyed. Reed-Sternberg cells usually derive from B cells. Rarely they can come from T cells. And this fits with our definition of lymphoma being a malignancy of lymphocytes like B cells and T cells. The Reed-Sternberg cells have very unusual markers. They are positive for CD15 and CD30. They are not positive for the standard B cell markers like CD19, CD20, and CD21 and 22. These markers are found on normal B cells, but they're not found on Reed-Sternberg cells. Instead, Reed-Sternberg cells have these two unusual markers, CD15 and CD30. And although Reed-Sternberg cells are the hallmark of Hodgkin lymphoma, they're also sometimes seen in other disorders. Here's a picture of a Reed-Sternberg cell. You can see that the nucleus is split into two halves, and it looks like the eyes of an owl. You can find many, many pictures of this in pathology textbooks and online. You should become very familiar with it before step 1. As I said before, the malignant cell in Hodgkin lymphoma is the Reed-Sternberg cell. What's unique about this lymphoma is that the malignant cells are a minority of cells in the enlarged lymph nodes. Usually, Reed-Sternberg cells are only 1 to 5% of the cells inside an enlarged lymph node of a patient with Hodgkin lymphoma. Most of the cells inside that enlarged node are reactive cells, and these cells are reacting to the large number of cytokines that Reed-Sternberg cells release. If you can remember that Reed-Sternberg cells release lots of cytokines, it can help you remember that B symptoms are much more common in Hodgkin lymphoma than in most non-Hodgkin lymphomas. In addition, it can help you remember another high-yield feature of Hodgkin lymphoma, and that is that it may lead to hypercalcemia. The reason for this is that one of the reactive cell types is macrophages, and macrophages contain the enzyme 1-alpha hydroxylase. This enzyme converts 25-hydroxyl vitamin D to 1,25-dihydroxyl vitamin D, the active form of vitamin D. So in the setting of Hodgkin lymphoma, you can get overactivity of macrophages and excess active form of vitamin D, and that can lead to hypercalcemia. A very common presentation of Hodgkin lymphoma is with cervical lymphadenopathy, so enlarged painless lymph nodes in the neck region, often together with B symptoms. Hodgkin lymphoma spreads in a very predictable manner from one set of nodes to another. For this reason, limited disease is highly curable because it's unlikely malignant cells have spread to distant and remote sites. Stage is one of the strongest predictors of prognosis, so if it's caught early when it's limited to the cervical region, it's often highly curable. Hodgkin lymphoma has a bimodal age distribution with peak incidence at age 20 and also at age 65. Some important risk factors include prior Epstein-Barr virus infection. Recall that this virus infects B cells, so it should be easy to imagine that it can lead to Hodgkin lymphoma. Hodgkin lymphoma is also more common on patients who are immunosuppressed, for example, HIV patients or patients who are post-solid organ transplant and taking large dosages of immunosuppressants. It's also more common in patients who have autoimmune diseases like rheumatoid arthritis and lupus. These disorders involve the immune system, including lymphocytes, and so it can lead to this lymphoma, and it's treated with chemotherapy and radiation. We'll talk more about that later. There are a number of subtypes of Hodgkin lymphoma, and I've shown you the way they are classified on this slide. So most patients have the classical form of Hodgkin lymphoma. This form is classified by the cellular background surrounding the Reed-Sternberg cells, and we'll talk about all four of these types in the next few slides. There is a rare type that has cells that are a variant of Reed-Sternberg cells, and that's called the nodular lymphocyte predominant type of Hodgkin lymphoma. So we'll talk about that rare type first. This is called lymphocyte predominant or nodular lymphocyte predominant Hodgkin lymphoma. It's a rare variant of Hodgkin lymphoma. In this version of Hodgkin lymphoma, the malignant cells are a variant of Reed-Sternberg cells called LP cells. LP stands for lymphocyte predominant. They're also sometimes called popcorn cells because they look like popcorn. I'll show you a picture of them on the next slide. These cells have unusual surface marker expression. They lack CD15 and CD30. Instead, they express CD20. CD20 is a traditional B cell marker, and it is expressed by these LP cells, and the usual Reed-Sternberg markers CD15 and CD30 are absent. And here's a picture of a popcorn cell that you see in this rare variant of Hodgkin lymphoma. Much more common are the classical forms of Hodgkin lymphoma, and among the classical forms, the most common subtype is called nodular sclerosing. It gets its name because the tumor forms fibrous tissue which surrounds portions of the tumor, creating nodules, hence it's called nodular sclerosing. This is the most common type of Hodgkin lymphoma overall. 60 to 80% of Hodgkin lymphoma cases are nodular sclerosing. It's more common in women, and that's unusual. Most forms of Hodgkin lymphoma are more common among men, but not this one. Another feature of the nodular sclerosing subtype is that it often spreads to the mediastinum, so it can present as a mediastinal mass on chest X-ray. In addition, the Reed-Sternberg cells, when viewed under the microscope in this form of Hodgkin lymphoma, are surrounded by a clear space. This is called the lacunar variant of the Reed-Sternberg cells. This is a slow-growing or indolent lymphoma, and it has good long-term survival and cure rates. And on this slide, I've listed the three other subtypes of classical Hodgkin lymphoma. The first one is called mixed cellularity. It can have eosinophils, neutrophils, macrophages, and plasma cells. In particular, it often has lots of eosinophils, and that's one of the ways it's recognized under the microscope. There is a form called lymphocyte-rich, which obviously has lots of lymphocytes. This form has an excellent prognosis. There's also a form called the lymphocyte-depleted form of Hodgkin lymphoma, and this type has a poor prognosis. An easy way to remember this is just to remember that the more lymphocytes, the better the prognosis. On this slide, I've just pointed out some of the clinical features of Hodgkin compared with non-Hodgkin lymphoma. We'll talk about non-Hodgkin lymphoma in another module, but Hodgkin lymphoma, as I already told you, is often localized and spreads from node to node, and it rarely has extranodal involvement. On the other hand, non-Hodgkin lymphoma often involves multiple peripheral sites. It can have a non-contiguous spread from one set of nodes to another, and extranodal involvement is much more common, including the GI tract with bowel wall thickening, or the skin, or many other organ systems. As I mentioned before, Hodgkin lymphoma is usually treated with a combination of radiation and chemotherapy, and if it's caught early, it's often curable. In terms of chemotherapy, there are many different regimens, and I don't recommend you try to learn these for step one. They're highly complex, and the regimen is tailored based on the patient's subtype of Hodgkin lymphoma and the stage. Let me just mention one of the most common regimens so you're familiar with it before you start your clinical rotations, and that's called ABVD. And each of the letters in this regimen stands for one of the chemotherapy agents. The A is for adriamycin, which is the trade name of doxorubicin. It's a cytotoxic antibiotic chemotherapy agent. The B is for bleomycin, which is another cytotoxic antibiotic. The V is for vinblastine. It's a microtubule inhibitor. And then finally, the D is for dacarbazine, which is an alkylating agent. And that concludes our module on Hodgkin lymphoma.